I'm pleased to present to you today's speakers, Professor Galderisi, who is a pediatric endocrinologist who completed his pediatric training in Italy at the University of Padua and obtained his PhD at Yale University in the US. He's currently an associate professor of pediatrics at Yale University. Dr. Galderisi's research focuses on developing metabolic endpoints to accelerate clinical trials aimed at preventing type 1 diabetes. And drawing on his expertise in vivo functional assessment of beta cell function gained during his PhD, he has characterized the metabolic changes that occur in the preclinical phase of type 1 diabetes. His work has revealed a more complex metabolic phenotype than the simple decline in insulin secretion traditionally associated with the disease onset. In particular, Professor Galderisi has demonstrated a concurrent reduction in both insulin secretion and insulin sensitivity in children with islet autoimmunity compared to their healthy peers. He has further identified significant metabolic heterogeneity within the current staging system for preclinical type 1 diabetes. These findings support the use of refined metabolic markers in prevention trials, an approach expected to significantly influence the design of such studies in the coming years. Currently, Professor Galderisi is investigating the metabolic phenotype of early stage type 1 diabetes, with a particular focus on the role of incretin hormones in stage 1 type 1 diabetes. He is also the principal investigator of an NIDDK-sponsored study exploring the use of semaglutide in children and adolescents with obesity and MASLD. Professor Galderisi, the floor is yours.
Thank you. Thank you for inviting me. In the next 15 minutes, we will discuss part of this work, actually. We will focus on a paper we recently published with the TrialNet Consortium. And the overall goal, basically, is to understand not only what happens before the onset of clinical type 1 diabetes, but also how can we measure it, and if we perform an intervention, like during the disease-modifying treatment trials, how can we measure the efficacy of this intervention? So let's start with something probably most of you are familiar with, the idea of stages. The idea of stages of type 1 is not at all new. It dates back 1985, 86, when Eisenberg described first the disease. Today, we sort of added some additional layers to the story of stages, and I want you guys to have in mind this picture only because it's a sort of glossary for our conversation. So we refer to stage 1 when people have at least 2 autoantibodies. We refer to stage 2. Some people use some sub-stages when people have at least 2 autoantibodies and some alteration of the glucose profile, not yet meeting the criteria for clinical diabetes. What is the important piece of the story is that once we identify the stages, we can give people a risk. Generally, it's a sort of growing risk from 10% when people have about a single autoantibody up to 75% over 5 years period when they are in stage 2. The important part of the story is when you have at least 2 autoantibodies, we know that your lifetime risk is about 100%. This means the disease does not start anymore as we used to think here in stage 3 when you have the clinical disease. The disease starts here. So all the intervention we want to perform to prevent type 1 diabetes have somehow to focus on these early stages. One of the problems we have when we discuss of stages and the sort of picture of the disease is what should we measure? Let's say you want to design a trial, as they have done. You want to design a trial in order to prevent the disease. What we have been doing until now, it's you enroll people, you randomize them to either one treatment or the other, and then you tell them, okay, you wait for the disease to happen. This is, I have to say, a bit hard for family to say, okay, I might be in the placebo arm, and what they're telling me is, no matter what I got, basically I had to wait for 2, 3, 5, 6 years, whatever, and then we will see what the story is. So ethically speaking, today, design a clinical trial to prevent type 1 is hard. It's time consuming because basically the measurement endpoint we need to use are the time to disease progression and somehow the A1C. It's time-consuming, money-consuming, and this is probably one of the reasons the only drug we have on the market in the United States and probably soon on the market in Europe or in some European countries, the anti-CD3 teplizumab, it arrived on the market after about 20 years, like bench to market time, which is a long time. The goal of not only my work, but our research group work has been to identify some early markers here, which could track disease progression and response to treatment. And today we will focus on metabolic modeling. I will mostly talk about the oral minimal model is one of the ways to make metabolic modeling. Full disclosure, there are other people and other models which have been used and which are absolutely valuable. My expertise is on this one, so that's why I will mostly talk about the minimal model, and I will try to give you like a simplified version of what it is. Metabolic models basically are simplified ways to describe components of the metabolic phenotype. They start from the biology. They could be risk indices, but they're not designed the same way we design risk indices. A risk index is something we retrospectively derive from an existing cohort. We put together parameters, we make a statistical model, and we see if these parameters, these variables, predict something. A model wants to reflect biology first. So the existing metabolic models have been validated with more invasive tests toward the actual biology. They can include individual variables. And the first question a metabolic model tries to answer is, what is the actual metabolic phenotype? That means what is the actual insulin secretion, what is the actual insulin sensitivity or clearance, which means we validate the model versus the gold standard test for that characteristic of the metabolic phenotype. A risk index is validated toward the risk we are trying to measure. So they are not exactly the same thing, even though we will try to use basically models to predict a risk, and sometimes we also do the vice versa, which is not exactly correct. The minimal model and other models try to describe is basically on one side insulin secretion, and mostly the two phases of insulin secretion, the early phase and the late phase. And we do that by measuring glucose and C-peptide for secretion and glucose and insulin for sensitivity. Why this difference? Because C-peptide is unaffected by the first hepatic pass. Therefore, we believe it's a much more reliable marker for secretion than insulin itself, because about 80% of insulin is cleared by the liver during fast. So measuring insulin as a marker of secretion is not really the right move. And then the model describes each of these steps with linear equations, not entering into the details, but basically we simplify each compartment and each flux from a compartment to another, a biological compartment, using an equation. And some of these variables can be measured. In our case, we can measure glucose, certainly. We can measure C-peptide for secretion and the rate of change of them. That's all we can measure, and we try to make our best to estimate the biology behind it. We use this thing in different contexts. Today we will discuss the use of oral minimal model derived metrics to describe the response to the anti-CD3 teplizumab, the only drug today approved by the FDA for those who are 8 years and older with stage 2 type 1 diabetes. There is not yet approval for this drug in Europe, even if in many countries the drug has been used under, we say, compassionate use. If you have questions, we can discuss it afterward. With the TrialNet group, basically, we went back to the pivotal trial that led to the approval of teplizumab by the FDA. And we tried to answer this question. Can we identify treatment responders to the anti-CD3 teplizumab in stage 2 type 1 diabetes, which is the original cohort of the trial, using a 3-month percentage change of insulin secretion, measured using the minimal model. Quick background, what is teplizumab? Immunotherapy in type 1 is a sort of complicated box. teplizumab acts as a partial agonist for the anti-CD3 receptor. As a result, it induces functional energy of the T effector cells and also promotes the development of T regulatory cells. In short, teplizumab has the, let's say, the positive effect of promoting T regulatory cells, which somehow prevents the disease, to make it simple, and he inhibits T effector cells, which is sort of a unique feature of the drug. And the other thing is this effect, immunologically speaking, persists even after the end of treatment. In the pivotal trial, they used the drug for 14 days, and then we keep measuring the effect. This is the survival curve. In blue, you can see the treatment arm. In red, you can see the placebo arm. During the first evaluation of the trial, the authors concluded that the drug basically led to a median 2-year delay of disease onset, so clinical onset of disease. And more recent analysis showed us that basically there is up to 5 years median delay for those, the blue people, who received the treatment, just again, one cycle of treatment. As I said, the effect on the immunological effect tends to persist. That's why we have such a long response, even if people are not receiving the drug anymore, or there is no second or third cycle, at least in this study protocol. Still, there is a question. As you can see, some people, you can see from the numbers, which are not big numbers actually for these trials, some people still progress faster than others. So in the Diabetologia paper, we built on this study. We basically started from an idea. We wanted to understand why some people, let's say, respond better than others. Technically, in the placebo group, and this is something that has been confirmed in many other cohorts of people with stage 2 type 1 diabetes, on average, half of the people we define as having stage 2 disease, they progress within a couple of years. Half of them, they stay disease-free longer than 2 years. So we said, okay, we define rapid progressor as everyone who progress within 2 years, and slow progressor as everyone who progress later than 2 years. And we want to understand, how do they look like? Do they look like do they look alike at the beginning? Do they change over time? What happens? In the teplizumab group, actually, the group of people, due to the drug effect, obviously, where the disease, a disease-free time longer than 2 years was certainly bigger. 70% of people did not progress before 2 years. So who are them? This is what we identify. At baseline, here you can see on the left part of the table, the placebo group, slow and rapid progressor, defined as I described. On the right part, teplizumab, slow and rapid progressor. Notably, traditional risk indices like index 60 or DPTRS, which are designed and are calculated using fasting C-peptide and fasting glucose, or 60-minute C-peptide and glucose in the case of index 60, they differ at baseline between rapid and slow progressor placebo. They sort of tell us that these people are at a different stage of the disease. The teplizumab group, this is probably because of the drug effect. There is no difference in index 60. There is a very small difference for the DPTRS index. And in terms of insulin secretion at baseline, there is a tendency for higher insulin secretion at baseline for slow progressor, which is not significant. In other terms, we can say that they start roughly from, at least in the teplizumab arm, rapid and slow progressor, they start from the same place. But then how do they move down the line? Here, in blue, this is insulin secretion calculated using the minimal model. Here we represent the percentage change in the two groups. As you can see, the red lines are those who receive the treatment. The rapid progressor with teplizumab, which are the dashed line, you can barely see probably, they tend to have a sort of smaller response, if you want, at 3 months. 3 months was the first time point we measure the insulin secretion with an OGTT after the treatment, then the rapid progressor. And you see that after 12 months from the first cycle of treatment, the slow progressor, the solid line here, they still have a slightly higher insulin secretion than the rapid progressor. And in terms of how do they look like, the rapid progressor of teplizumab, they look like the slow progressor, blue solid line of the placebo group. Don't forget, slow progressor in the placebo group, they were those ones who were somehow at an earlier stages of the disease. So it means that the drug somehow is giving everyone an advantage. That we can go back to this concept afterward, and probably on the survival curve you will see much better. We didn't find a significant effect of the drug, see the red lines, on insulin sensitivity, while we observed in the placebo group, again the blue lines, a lower insulin sensitivity in the rapid progressor, which means that the rapid progressor somehow, they tend to have lower insulin sensitivity and lower insulin secretion in stage 2 disease. While for clearance, the clearance response, it's a bit delayed if you want, and we saw that insulin clearance was reduced somehow in slow progressors versus rapid progressors. The way we explain it, we do not know really the mechanism. We cannot explain this finding. We observed similar finding in other papers, in other studies we did. The idea is that reduce insulin clearance differently from what we have seen in type 2 diabetes. For type 1 might be a sort of compensatory mechanism to basically counterbalance the reduced secretion. So if you have less insulin, let's say your liver tries to clear less insulin to maintain constant the circulating insulin level. This is an hypothesis. We do not know the mechanism, but we see this find sort of consistently across the stages, the preclinical stages in type 1. What about the clinical relevance of these findings about secretion? Here we stratify the population by the 3-month change of insulin secretion. The minimal model used the phi term to just to describe insulin secretion. Phi, or this Greek letter, stands for secretion in the model equation. So basically the dashed line is the people who are losing more than, represent the people losing more than 25% of the baseline insulin secretion over 3 months. And as you can see, they have a steep rate of progression over time toward the clinical disease. While the people who maintain their baseline insulin secretion, so the one losing less than 25% of the baseline value, they tend to have a slower progression. And this is still true when we stratify the cohort again by treatment arm. When you look at the teplizumab arm, which preserves more the baseline insulin secretion at 3 months, you see that the progression is much slower. So as you know, in the survival curve, like the lower is the bar, the better is the outcome for these people, while clearly those ones who are the worst situation are the placebo people with a rapid loss of insulin secretion. Even if these are very small numbers, I have to say, when we stratify the cohort, the take-home message is in stage 2, not everyone is really at the same stage. Some people have a faster disease progression. These are the people losing more beta cell function, which we express here using the model. And these are the people who will be faster progressor within stage 2. We try to do the same thing with clearance, but since we observe the difference in insulin clearance at 12 months, not at 3 months, we stratify a population by insulin clearance. And as I said, more or less same story. When you reduce your insulin clearance, solid line, you tend to progress slowly. We hypothesize this is a compensatory mechanism. As I said, we do not know the mechanism. Similar story when you stratify the cohort by treatment arm. To summarize, in the TN10 trial, the teplizumab trial, we observed rapid progressors in both placebo and teplizumab arm as the people who rapidly lose the insulin secretion. We like more than 25% over a 3-month period. The 3-month period is only because we didn't have any OGTT before 3 months. So this was the first available OGTT. Insulin sensitivity does not seem to play a big role. An increased insulin clearance seems to worsen the speed of progression. On the contrary, slow progressors in both the arms are the people which do not lose more than 25% of insulin secretion, who have an increase of their sensitivity and who reduce their clearance as a compensatory mechanism, probably. What is next after this? We have been working, one thing I didn't mention at the beginning, to properly and accurately estimate model parameters. The more time points we have, the better it is, especially for the first 30 minutes. During the teplizumab trial, the OGTT they performed didn't have any time point before 30 minutes. This limits our ability to estimate like early phase insulin secretion or late insulin secretion, so we did not describe subcomponents of insulin secretion, but we will probably do that because we are funded through TrialNet by Breakthrough Type 1 Diabetes to add these early time points to all the OGTT the TrialNet performs as part of the monitoring study in the US. And what we are actually working now with colleagues from different countries in Europe and in the US is trying to validate the model on larger cohorts to see if these numbers I showed you in a very small cohort overall, they are still true and they still predict, in our case, this is progression, and how they perform as when compared to the actual risk indices we know. I'm open for questions. I hope.
Yes, thank you. Thank you for an excellent talk and presentation and such an important subject, really. So actually, I would like to ask that you presented that this the loss of insulin secretion during the 3 months time is a good predictor of what happens later, but is that like at the moment the kind of best what is known, or are there some other markers? What other markers or you would maybe present that could best describe what happens later?
There are actually two answers to this question. The first answer is about the temporal window. The temporal window is definitely forced by the study design.
Mm-hmm.
Probably you want to know it sooner. I mean, we don't know if, we tried to test a 6-month or a 12-month temporal window, which did not perform as well as the 3-month. We do not know if an earlier assessment, like a month or 2 months, would have been better. This we do not know. We tested also index 60, DPTRS, which are the two most popular, let's say, and most used indices. They did not perform as well as the minimal model indices at 3 months.
Okay.
But in the general population, like when you look at the placebo cohort here or in the general population in other studies we have done, definitely index 60 and DPTRS, they perform well in terms of risk. So my point is there is a difference between risk for disease progression and treatment response. Sometimes measures that perform very well as predictor of progression are not exactly a good fit for treatment response at the same time. I hope you see what I mean.
Yes, excellent. And actually, then I would have a follow-up question on like in this study that teplizumab was used, but then are there other like such kind of compounds that are at the moment like the most interesting ones in your field that you would feel that are investigated like this?
You mean if we'll try to do the same thing with other like studies, like prevention studies? We try basically, and hopefully you will see soon the manuscript. It's not yet out, but we will present some preliminary data at the American Diabetes Association. We try to do the same thing with the abatacept trial in stage 1. Basically, the abatacept is a CTLA-4 immunoglobulin, and it has been used in a prevention trial targeting stage 1 disease. So people with 2 autoantibodies know this glycemia. The trial did not meet the end point. There was delayed disease progression, but I mean the authors, they saw a sort of response at 12 months of treatment in C-peptide, and we try to stratify people using the minimal model at baseline to see if there is a responder group, because again the analysis starts from the same standpoint. We include people in clinical trials using stages, but within a stage you have a large heterogeneity. So probably some people in stage 1 or in stage 2, as this case, may be better responder to a treatment than others. So yes, we are trying to do exactly the same thing with some old trials and possibly with some new trials that we can talk about like next year if you guys still want to discuss this subject.
Janislava, do you have other questions?
Yeah, Professor Galderisi, you mentioned that you're further looking at bigger cohorts to validate your results. So I was wondering which cohorts are these? Are you looking like worldwide?
We are
or also in Europe?
At this time, since TrialNet, so the US-based basically screening and monitoring, they accepted to modify their OGTT in the national screening program, adding these time points and measuring C-peptide, all the time points. We are working on the TrialNet cohort. This project started a couple of years ago, was funded by Breakthrough Type 1. They literally paid for the extra time points to implement the screening, and they've been supporting us for the analysis. So yes, that's the actual cohort. I say by the end of this year we should be able to give some answers, because we will have enough data to test this hypothesis. There are some countries like the UK, mostly through the Inodia consortium, in Europe, who are on the same page for this specific project. So some sites in the UK have done multiple time points or GTT, and they will probably be part of this analysis.
Excellent. Can I ask, how do you think that what would be as because I'm a clinician also, so how for clinicians, how would we best use this data in clinic at the moment? Of course, I know it's a work in process, but
that's a good point. The point is, let's say a more complex test, that this is my personal opinion, a more complex test is probably something we want for a clinical trial, because in a clinical trial you need to be very accurate, you need to understand what's going on, and if you have additional questions at the end, you cannot redo the trial. It takes quite a long time. So I believe, but the ultimate goal of this kind of studies is to say, okay, this is the time point I want to measure, this is the variable I want to measure, then I need something easier to measure. For example, for stages, what we want at the end of the day is it's an easy matrix which will allow us to better, address people to a certain treatment. So hopefully from the analysis we will understand who are the people at higher risk, but we will also understand who are the people at lower risk for progression within each stage, and probably these are the people we do not need to monitor as frequently as the other ones. So it's a two-way answer. So we want to do more in some people and we want to do less in some other people, because it's still a very time and money consuming process, especially when you do not have that many options for people with preclinical type 1.
That's true.
Wonderful, many thanks. I'm personally very much looking to attending your talk at this year's ADA. I'll make sure that I am there.
Yes, I hope to see you both or anyone from the EST. You will enjoy the talk. I hope so. Thank you.
Thank you very much.
Bye.
Bye.
Bye.